Good afternoon, everyone. My name is Sharon Rounds, and I am the uh, Program Director for Advance Rhode Island CTR. And this is our monthly research seminar series. As many of you are aware, we feature in this series both senior investigators who are performing clinical and translational research. And also, we're very pleased to feature new investigators who are recipients of the highly competitive research awards offered by Advance Rhode Island CTR. Ordinarily, we have two talks in this session, but today, unfortunately, the second speaker had a family medical emergency this morning and was unable to attend. But we are very, very pleased to welcome Maria Steenland and Ben Brown, who are multi-PIs on Advance CTR Pilot Project. Maria is Assistant Professor of Population Studies and Health Services, Policy and Practice at the Brown School of Public Health. And Ben is the Mimi Pishi Assistant Professor of Obstetrics and Gynecology at the Alpert Medical School of Brown University. I will ask the attendees to please put your questions, comments in the chat, and we'll attend to them at the end of the presentation. So I'm handing things off now to Dr. Brown, and he will take it away. Thank you.
Thank you so much. We're really excited to get to be here to talk with you all today. And of course, we're really grateful to Advance CTR for supporting our work. We're excited to get to share our preliminary results with you all. Our topic today is access to long-acting reversible contraception removal services among Medicaid-covered postpartum individuals here in Rhode Island. And then I'll just point out our emails are on the screen here. So please, of course, reach out if you'll have questions or want to touch base afterwards, because we, of course, look forward to collaborating with folks on this and future projects. We don't have any disclosures. And we've consulted the AMS Guide to Creating Inclusive Curricula in preparing this talk. So I want to start off by talking about the concept of reproductive justice, which is really a foundational framework that certainly I strive to apply in my clinical care as well as my research and teaching. And I think really underlies the entire project and the rationale for our project today. So reproductive justice is the human right to maintain personal bodily autonomy, have children, not have children, and parent the children we have in safe and sustainable communities. This is a framing of health rights, health justice that arises from the work primarily of Black women in the mid-90s. Who did not see their lived experience reflected in the broader feminist movement, the broader abortion rights movement, and RJ comes from that place. And I want to really name that positionality both for reproductive justice, but also my own positionality vis-a-vis reproductive justice. I come from a place of, I occupy a place of a lot of privilege. I'm a cis-het white man. Knowing the history of reproductive justice and knowing my own positionality, I want to be super clear that I don't consider myself a practitioner or an author of reproductive justice. But as a clinician, as a researcher, as a teacher, I strive to be grounded in this framework and understand the world through this lens of reproductive justice, because I think that is critical to me being the most effective, patient-centered, equity building, justice building clinician and scholar that I can be. And that's the angle that I come at reproductive justice, or the way I want to kind of situate my view of reproductive justice vis-a-vis our research project. So to unpack the concepts of RJ a little bit more, RJ is inclusive of people of all genders, and it's fundamentally intersectional, meaning that we all come to healthcare spaces, health seeking behaviors as a sum of many influences, at the intersection of many identities, and the ways that people are able to access care, are barred from care, are facilitated in getting care, there are a variety of influences that result in somebody's ultimate ability to access or not access care, and the quality of that care, right? And so we think about factors like racism and xenophobia and misogyny and queerphobia, and recognizing that RJ incorporates that intersectional awareness in how we think about and critique health systems. Importantly, RJ centers the most marginalized, and what we kind of mean by that is that until we know that somebody who has historically been the most marginalized, the most excluded, the least centered in healthcare spaces, until people who have historically been the most marginalized are able to access care unencumbered, we will not know, we will not have a just system. So we center the most marginalized in thinking about RJ. And ultimately, RJ is about access, not choice, right? So on some level, it doesn't matter what the law says if people can't access care, if people can't be healthy, if people can't do the things they need to do to be healthy in their reproductive and sexual lives, then we don't have RJ. And so thinking specifically about contraceptive care, and kind of with that all borne in mind, contraceptive care is ultimately, these are patient-sensitive decisions. Shared decision-making, eliciting patient values should be fundamental to how we provide contraceptive care at the kind of clinical encounter. But unfortunately, a lot of practices reinforce contraceptive coercion or non-patient-centered contraceptive management. And so we see examples of that from research like the Contraceptive Choice Project, which was and is a really seminal project for some important kind of important reasons of what we were able to see about the effectiveness of contraception, and some frankly ignoble reasons, some problematic reasons, where the Contraceptive Choice Project really focused on certain methods of contraception, counseling about certain methods of contraception above and beyond others, which ultimately is not consistent with a shared decision-making approach. Likewise, we see clinician counseling practices that vary from person to person and situation to situation, and we know that that biased counseling can hamper patients' abilities to access what they view as the most optimal contraceptive method for them. And then likewise, there can be barriers to method discontinuation. So when we have methods that require provider input or provider involvement to discontinue the method, we can see practices that act as barriers to stopping those methods. And again, throughout this, we see that thinking in an intersectional way, we know that there will be disproportionate effects on people experiencing racism, misogyny, queerphobia, xenophobia, in terms of how all of these particular burdens and this kind of contraceptive coercion might fall. So for our specific project, we looked at long-acting reversible contraceptives, or LARC devices. There are a variety of different LARC devices available around the world. In the United States, there are 4 hormonal intrauterine devices, so the T-shaped devices that sit inside of the uterus, and there's 1 copper IUD. There's 1 subdermal implant available in the US, and this is a sort of matchstick-sized device that sits under the skin and releases hormone to prevent pregnancy. And all of these are highly effective. They have very low rates of pregnancy for people who are using these methods, and they tend to have low side effects. They tend to be well tolerated, and globally, people who choose these methods tend to like them well. However, one of the major challenges with them is that they require provider involvement. They require healthcare worker involvement, certainly for insertion and largely for removal. Sometimes some people can self-remove their own IUDs, and there's an expanding research, there's an expanding literature about that. But broadly speaking, both for insertion and for removal, providers tend to be involved. And all of these devices can be placed postpartum. So for somebody who doesn't want to conceive in the immediate postpartum period, these devices can be placed. The largest barrier for a long time has been a financial barrier. So the way that childbirth services are billed largely in this country are as a global fee. And so irrespective of what additional care somebody might need, they may not, insurance may not pay for additional care. And so CMS in April 2016, after a lot of advocacy from many groups, published a bulletin trying to give technical guidance to states for how they could unbundle LARC, immediate postpartum LARC devices to facilitate access for people around the country. And 45 states have Medicaid guidance on implementation, so the majority of states now. And there are a variety of different approaches that states take to this, either unbundling the cost of the device, the cost of the insertion, or both. In Rhode Island, it's the insertion that is unbundled, and that's what facilitates providers to be able to bill for providing this service separate from a delivery. And so tying that all together, the rationale for our study is that there are some ethical concerns that arise from this, right? So biased counseling and difficulty obtaining removal have been found in the qualitative literature, but there's little quantitative evidence available to document the extent of those kinds of issues. And so we wanted, this pilot study, the goal was to fill a gap in that evidence base to understand what people's experiences were with contraceptive coercion, and primarily really around this issue of, is it hard to get a device removed if you want it removed? So I'm going to pass over control to you, Maria, and we'll see if you can take the slides from here.
Sounds good. Okay. Okay, have control, it seems. Great, thanks, Ben. Yeah, so I'll move on to talking about our study's methods. First, our study's aims were to, aim one was to document the % of individuals who desired or had their LARC removed by 1 year postpartum. And the purpose of this aim is really to get a sense of the underlying sample size that we would need if we were to scale up the study, since questions about barriers to LARC removal are really only relevant for people who wanted their LARC removed in the first place. So in terms of future sample size and power calculations, this was a really important statistic for us to try to document. Aim two was really the sort of bulk of our interest, and that was to document barriers to LARC removal among individuals who received a postpartum LARC. This is a study that took place at Women and Infants Hospital. Women and Infants Hospital is the location of childbirth for around 80% of people who give birth in Rhode Island, or around 8,500 people annually. And it's a great setting for us in terms of our interest in inpatient or immediate postpartum LARC, because it's a hospital that really scaled up delivery of this service after the Medicaid policy change that Ben referenced, providing a separate payment for the placement of immediate postpartum LARC. So since the policy's implementation in Rhode Island, there's been about 10% of the Medicaid, people who have a Medicaid paid birth, that women and infants get an immediate postpartum LARC, which is much higher than most hospitals in the United States, even in states that have implemented these Medicaid policy changes. We identified our patient population using hospital administrative records, and we pulled records for people who had a live birth at Women and Infants between January and June, in either 2022 or 2023, and those people who received a LARC in the hospital. We also pulled information about the language preference of the patient as well as age of the patient. And we excluded people who whose primary language was neither English nor Spanish, and people who were younger than 16 years of age. Our data collection took place between January and September of this year. And throughout the study, we maintained an RA team of one person who collected the surveys from primarily English speakers, and another RA who collected information from those people whose language preference was Spanish. And we included, or the RAs did up to 5 call attempts to try to reach patients or potential respondents. And those call attempts took place at different times of day and different days of the week to kind of maximize our potential opportunity to reach people. Once an RA was able to speak to someone by phone, if they were interested in participating in the study, they could consent and complete the survey either over the phone with the RA at the time of the call attempt or at a later scheduled time that was more convenient for them. And they could also complete the survey electronically through an emailed survey. All of the patient information about tracking call attempts, as well as the survey data itself, was maintained in a REDCap database, which was stored at Women and Infants Hospital to maintain patient confidentiality throughout the research process. So one thing I wanted to talk in a little bit more detail about was the actual design of our survey instrument, because I think it ended up being an important contribution of the work that we did, even though it did result in some delays in us starting our survey work. We had planned to use or adapt a series of questions from a survey called the National Survey of Family Growth, or NSFG. And NSFG is a population representative survey in the United States. It's very long-standing, and it's really been the main source of information about fertility and contraceptive use for a long time. In the 2017 through 2019 iteration of NSFG, the survey added some questions related to LARC, barriers to LARC removal specifically, which seemed to be, great for us because they gave us a previously validated set of questions that we could adapt. So the way these questions worked is essentially for respondents who had used an IUD or an implant in the last 10 years, they were asked if they had difficulty, that's the first question here on the slide, getting their IUD or implant removed. And if they responded yes, they would move on to a subsequent question where they would be asked to indicate the reasons that they had difficulty with IUD or implant removal. And the concern that we developed after piloting our own survey with respect to this series of questions is that it's really whether or not the respondent goes on to answer the question about difficulty with removal is really dependent on their understanding of the concept of difficulty in this initial screener question. And our sort of specific concern was that many people seem to be understanding the term of difficulty with respect to the actual extraction process of the removal. So for example, it can be difficult to remove an implant from the arm if it has migrated from its initial location. So sometimes clinicians actually have a physically difficult time taking it out. But our concern was that if that's the way people were understanding this question, they would never get a chance to report on some of the other types of barriers that we were also interested in. So what we did because of this concern was to redesign our survey instrument with the goal of asking people questions about barriers to LARC removal without a screener question. We also were interested in better understanding how respondents were interpreting terms like barrier, difficulty, and problem with removal so that we could select the language that would best, elicit the types of responses, or at least have respondents think about the types of barriers that we were interested in asking about. So we used a similar sampling, or the same sampling frame is our main study population. So those were people who had given birth, women and infants within the past year or two, and who had gotten a LARC, an inpatient or immediate postpartum LARC. We completed 11 English and 14 Spanish cognitive interviews. And what we came up with were these new survey questions, barrier-specific survey questions. So our questions asked, we were interested in 4 primary barriers related to insurance coverage, out-of-pocket costs, appointment availability, and clinician reluctance to remove the LARC device. And these questions were all asked without an initial screener question about whether they had any difficulties. So just to give you an example of what these types of questions sounded like, one of the questions was, to what extent did appointment availability make it difficult for you to have your IUD or implant removed when you wanted to? And the response options were not at all, somewhat, or very much. So I'll move on now to talking about the study results. So we included 217 respondents with a response rate of 41%. The average age of our respondents was around 30 years old. The majority of our respondents were identified as Hispanic, and most respondents had either less than a high school level education or a high school or GED level of education at the time of the survey. And just over 3/4 of respondents' childbirth-related hospital services were paid for by Medicaid. We collected some sort of basic information about LARC use in our patient population. So though all of the patients that we reached out to had an administrative record of receiving an inpatient or immediate postpartum LARC, 14% of the sample actually ended up receiving their LARC at a postpartum visit. About half the sample got IUDs and half the sample got implants, and the sample was split between those who had received their inpatient LARC a year ago and those that received it 2 years ago. Around 45% of respondents had wanted their LARC removed by the time of the survey, so within a year or two after placement, which is a pretty high percentage. There's a lot of, I think initially when LARC started to be used more in the United States, people referred to removals before the sort of expiration of the device as early discontinuation. But I think what we see here in this study, and this is reflected in other work, is that it's quite common to want a LARC removed much earlier than the device would expire, which is, I think, 5 years for implants, and depending on the IUD, could be between 5 and 10 years. So in terms of why respondents wanted to get their device removed, the most common reason was not liking the side effects. And around 21% of people also reported other. And this other category, which we did ask for write-in responses to, most often included things that we would think about as side effects, so things like bleeding and pain. And 14% wanted removal because of complications, and around 11% because they want to get pregnant. So this slide shows the percent of people reporting our first 3 barriers. So these questions were asked for all respondents who said that they wanted a removal or had wanted a removal by the time of the survey. So what we found was that 16% of people reported that insurance coverage was either somewhat or very much a barrier to them getting their LARC removed. around 9% of people reported that the cost, so this would be like an out-of-pocket cost associated with the visit, a clinician visit, was very much or somewhat a barrier to LARC removal. And around 22% reported that appointment availability was somewhat or very much a barrier to LARC removal. I'm going to talk separately now about the provider reluctance barrier, because that the population who was actually responding to that question is a little bit different than the other three, because for that question, we really only was really only relevant to people who had actually spoken to a clinician about wanting their LARC removed. So of those people, 34% had their, for 34% of those people saw a clinician who wanted them to wait before getting their LARC removed. And too fast, too fast. Let's see. I just keep going in the opposite direction. Okay. Oh, no. I wish I could just remember the percentage.
No, I'm trying to help you, and I feel like it's like the computer is like, there's too many people trying to change things.
Yes.
I think we're good. Is this where you want to be?
Yes,
right
this is it. We're here. Yes. So of those people who spoke to a clinician that wanted them to wait, only around 46% were okay with their clinician's recommendation, and the other 54% of people either weren't okay at all or were only somewhat okay with their clinician's recommendation that they wait. So we interpret this as a pretty high percentage of people who were asked to wait and really didn't want to, even after the clinician was recommending that they delay their LARC removal. So I'll turn things back over to Ben for the rest of the presentation.
Thank you. So to kind of reiterate some of the top level findings and what we draw from them, we saw a meaningful proportion of people, about 45%, who wanted LARC removal within 2 years. In other words, when LARC are placed immediately postpartum, at least in this population, it's predictable that there will be a meaningful number of people who are ultimately within a relatively short time period, certainly less than the expiration, kind of the use life of the device, will want that removed. The most common reason we found was side effects of various types. And in spite of that, and in spite of that being both kind of like a priori making sense from the clinical side that if somebody has a device placed, they might want it removed, and also then being a meaningful proportion of our population. Again, a significant proportion of people, about 35%, reported experiencing barriers to removal, which I think was not surprising to us, but is troubling to us. In looking at what those barriers are, and in thinking about some of the kind of policy strictures that might be leading to those barriers, certainly on the provider level or the kind of clinic level, the most direct kind of service delivery level, ensuring that providers really are grounded in a patient-centered reproductive justice approach to their counseling, recognizing that the person using the contraceptive method is the expert in whether they should continue it or not. Just speaking anecdotally of what I see in clinical settings, I would say it is not uncommon for providers to have a sense of having their own thoughts about what the best next step in terms of contraceptive management is for the patient, and that bleeding over into what their counseling looks like, which is not grounded in shared decision making, is not best practice. And so changing the way that people are doing their counseling approach is a key part of mitigating these barriers. Likewise, insurance coverage for removal. We see that cost and insurance coverage are are challenges for some of our patients, in spite of the fact that ostensibly they should have coverage for it. And we'll talk about that a little bit more in the next slide. And then just appointment availability. And certainly this is something across the board in terms of healthcare access, but we saw that people simply like couldn't get in to see a provider. And so if they need access to a provider to have a device removed, if they can't get an appointment, they can't get it removed. And that's a problem. And the experience of these barriers is likely to be context specific, right? There is a relatively low rate of postpartum uninsurance in Rhode Island, but certainly in a place where that's higher, then these barriers might be even more significant, a larger proportion of the population potentially. Again, speaking kind of anecdotally, my experience, I trained in Chicago, and different institutions have different contracts with different Medicaid service providers. And so you might be seeing somebody at one provider, you might deliver at a different provider, and you might be in network, out of network, even though you're just 50 blocks away from where your primary provider was. So the intricacies of the way that we set up these networks can be a real headache for patients as well as providers. And then likewise, we are at a time period where there may have been fewer interruptions in postpartum insurance during the pandemic era pause in Medicaid disenrollment. And so again, thinking about where these barriers might be higher, certainly in those states that haven't expanded Medicaid, haven't extended Medicaid coverage postpartum, and after the phase out of the continuous coverage requirement in March of 2023, we may very well see that some of these barriers are more significant or more common. So in terms of thinking about next steps, our goal is to take what we've learned here and scale up the study to other state contexts, again, recognizing that the barriers that people experience will be local, will be different on different local levels. So getting a broader sense for what that looks like in different places. And then likewise, to increase our sample size, we do want to be intentional in our study design to try to unpack specifically ways in which things like racism and classism may affect different people differently, and tailor our analytic and our data collection approach to help to unpack those dynamics. And likewise by device type, again, because the dynamics of how specific devices get removed, whether it's even possible to self-remove the device, differ between the devices, and in fact, actually, on the provider side, IUDs are generally easier to remove than implants. So just seeing if people have kind of different experiences of some of those barriers. These are our references. And we thank you very much for joining us, and we'd be happy to answer questions.
Fantastic. Thank you so much for really a terrific presentation, a very interesting study. We have a couple of questions. One is if you could just specify a little bit about the sources of your study recruitment, and if you intentionally oversampled Hispanic participants.
Yeah, I think I can take that one. So we pulled records from like the universe of people who met the inclusion criteria of our study. So we did not do any selection with beyond that. We included everyone who had given birth during the study period and who got an inpatient LARC according to their administrative records. We know that some people ended up getting their LARC at the outpatient visit after we spoke with them, but based on their administrative records. I also was very surprised to see the large share of people who identified as Hispanic in the study. But what I found was when I looked at inpatient hospital records that I obtained from the state of Rhode Island and I looked at specifically those people whose childbirth had been paid for by Medicaid and who had an inpatient LARC in their hospital inpatient records. These were separate from those that we got for the study. These were just publicly available. The percentage of people identifying as Hispanic in that population, which is essentially very similar to our population of interest, was very, very close. So I think it just so happens that in terms of the patient population whose care is paid for by Medicaid and who do get an inpatient LARC in Rhode Island at Women and Infants Hospital, around 70% of them are Hispanic. And so our patient population that's included in our study it mirrors very closely the underlying study population.
Okay. And another question is, do you think that this is a significant problem that should be discussed with the patient when LARCs are being considered for placement, that they might have challenges getting the device removed?
Yeah, I think that's a great question. As compelling as I think our data are, I am also mindful that this is a pilot study, and I think drawing a very broad conclusion from it is I think we shouldn't overgeneralize the results. But certainly when I am counseling people about contraception, I am very precise and specific to point out that that if at any point they do not want to continue their LARC device, they don't have to justify that to me in any way. They can just tell me they don't want their LARC device, and we will remove it. And I do think that making sure that people know that is my orientation as a clinician, and that can and should be their expectation of me and their other clinicians, that if they're done with the device, they don't have to justify it, we'll get it out. That is part of how I talk about LARC devices when I'm placing one. And likewise, if someone presents for a visit, to have it removed. I would also say that I think there is an unfortunate tendency in in lots of areas, I suppose, of healthcare and public health, to displace the onus for the shortcomings of a system back on the person accessing care. And I think that the broader message that I take away from these data, and assuming that larger data would show something similar, is the urgency to have systemic interventions to minimize these barriers, because I think that will ultimately be more effective at mitigating them.
Okay, another question from the chat. Realizing this wasn't assessed, do you have thoughts regarding the reasons why clinicians might discourage removal?
Yes, again, anecdotal, but I would say the reasons that I see people discouraging people from removal tend to be things like hoping and expecting that a side effect or a frustration with the method will get better over time. So kind of encouraging a method user to like wait it out to see if their bleeding improves or their pain improves, things like that. Or that clinician who is thinking primarily of somebody's biomedical complications in a prior pregnancy might say, I saw what happened. I saw how you suffered in your last pregnancy. I saw the complications you went through, and I don't want that for you again. And this IUD is helping to avoid that. Those are the narratives that I see, again, anecdotally. And I think that part of the challenge in the expectation being in changing individual behavior is that I think for most of the people that I've seen express feelings like that, they understand it in their own head as something that is patient serving. Like they recognize the biomedical side that they are worried about on behalf of the patient. But I think that's a fundamental misunderstanding of our duty in contraceptive counseling, which is a shared decision-making approach grounded in the patient's values, not our own values as healthcare workers.
So kind of a follow-up question that I have is, this is obviously a very sensitive and perhaps for some people difficult topic to address. Did you have any, did you do any patient focus groups or have any, Advance CTR does something called a studio where potential study participants are invited to comment on the study design. And I wonder if that approach might possibly change the way in which you pose your questions or even the types of questions that you ask.
We unfortunately did not do a studio, although that was something that I think would be of interest, and we were interested in pursuing. Our timeline was such that we kind of needed to get started very quickly. In the end, we experienced delays, even within that timeline, and probably that could have been a totally fine delay, but at the time we were still trying to shoot for the year-long study period.
Right. That's right.
Yeah, but I do think we ended up getting similar types of feedback through the cognitive interview process, because that process is open-ended questions. And these surveys were just 5 or 10 minutes long, but the cognitive interviews were more like a half an hour long and had more time for respondents to discuss in more detail their experiences. And I think certainly I learned a lot from those interviews. And I think those more detailed accounts of individual experiences ended up being reflected in the questions themselves.
The same comment might be that perhaps doing focus groups or studios with providers might similarly be helpful when you design a larger scale study.
Definitely.
Well, here's a plug, a shameless plug. I'm happy to say that Advance Rhode Island CTR, the Community Engagement and Outreach Corps, has started offering the opportunity for studios. We're booked for this year, but but for future studies, it's something to consider. Well, this is terrific. Thank you so much, Maria and Ben. I thought it was a very interesting and provocative question that you're asking, and one that will, gets us all thinking about the way in which we talk about things with our patients. And I want to thank the participants for attending. You will all be receiving a feedback survey shortly, and please take a few minutes to complete the survey and provide us with valuable feedback. And our next Advanced CTR seminar will be in 1 month, and we'll look forward to seeing you all again then. So thanks again, and have a great day. Bye-bye.
Thank you. Be well.